It's my pleasure to introduce Dr. Hernan Osorio, who is a senior consultant in the segment division at KKesh. And those who don't know him, he graduated from Columbia, National University of Columbia. Then he did a master's in ocular surface refractive surgery and uveitis. After that, he moved to Spain and did a PhD in visual sciences. And he had been a consultant at the famous Barraquen Institute in Barcelona from 2009 to 2015. He joined KKesh in 2015, where his specialty is subspecialty is ocular surface and biologic keratoprosthesis, particularly the tibial bone prosthesis. So, with this introduction, I would like Dr. Osorio if he can start with his presentation. Thank you, Dr. Osorio.
Thank you, Dr. Ahad, for the nice presentation. And this talk, okay. You can see right now? Yes, okay. Yes. This talk is complementary talk after the talk of Dr. Rawan Shabi did the last week, 1 month ago, excuse me. Then she was talking about the also fungal infection after in the patient that in the rims of the culture we have in the eye bank. We're going to continue with the same topic. Why this topic? Because this topic is in our hospital. There we have the long-term admission for this patient, and our outcome are bad outcomes. But when we are comparing with the worldwide literature, we are between the outcome in when we are comparing with Europe or America or even the Middle East, we have more or less the same outcomes. It's meaning that this disease is a really difficult disease for diagnosis and treatment. This is the content of the talk. We're going to start first with epidemiology. It's so different when we are talking about the incidence between developed countries of developing countries. In developed countries, the incidence of the fungal keratitis is increasing. If we are comparing when 15 years ago or even or closer 20 years ago, it's increasing even 20 to 20 times more, and it's related with the contact lens. Even it's not related with the outbreak we have in 2006 with the in America is well known, but also there are recent reports in Australia, also reports in Netherlands that this is still increasing the frequency there in Europe and is in these developed countries, and it related with the contactless wearers. In the developing world, they have a higher incidence, and is more related with the weather, because it's the country that is tropical or subtropical continent countries, and the etiology is also different. The percentage of infection keratitis is bacterial mostly in Europe, North America, and Australia, but is in China, in India, in Egypt, in Florida is mainly fungal. This article was published recently, and you can see the incidence that this is so high in countries like India or Nepal. It's also high in China and USA, but in the south of USA. And later on in this talk, I will explain in the treatment that one specific in groups, research group in China, India, and in Bascom Palmer, they are publishing a lot of articles that the current information that we are managing and the clinical trials are running by them. As I was explained before, the percentage of fungal keratitis between the all microbial keratitis is higher in the tropical countries. In Saudi Arabia, it's around between the 10 to 14% of the all infectious keratitis. And we can see also that some countries that we are expecting that they have a higher percentage of fungal keratitis. For example, Brazil, that is a country that is a tropical country, they have a really moderate to low percentage of fungal keratitis between the microbial keratitis. Regarding the risk factors, it's well known that the trauma with contaminated vegetation or soil is a risk factor, but I will explain later on that in Saudi Arabia is different. The climate, in tropical country, the filaments, in temperate country, the yeast, male agricultural worker, but it's different here. What the patient did ocular surgery that is so important in Saudi Arabia, compromised ocular surface. This is a well-known risk factor. And of course, los contactless wearer. That is more related with the Bausch and Lomb solutions. In Saudi Arabia, this article was published in 2011 by Sabaya Stenia in anterior segment division, and they include 124 cases. All the cases, the gold standard in this case was the biopsy, even the biopsy cell of the histopath of the cornea when they did the keratoplasty. The main risk factor in Saudi Arabia is previous ocular surgery. Right now is different, I will explain in the next slide, following by trauma, the use of topical corticosteroids, diabetics, and in less percentage, trachoma, systemic diseases. While the surgery was the main risk factor, because it was related with the extracapsular cataract extraction. Patients with did combined surgery, keratoplasty plus extracap, or this trabeculotomy but extracap, they have a high risk in these cases. You can see there's a lot of cases, but when in the hospital they start to move to phacoemulsification, this percentage disappeared totally. There was not any patient related with the fungal keratitis and fungal endothelium related with phacoemulsification. Maybe something was related with the, I don't know, maybe this contamination of some material or something, but this is a well-recognized factor in the hospital. Regarding the diagnosis, we know that it's so difficult to do a clinical diagnosis of the microbial keratitis. In this beautiful study published in 2007, this study was done with a well-experienced corneal specialist. This well-experienced corneal specialist, they diagnosed accurately 76% of the microbial keratitis, but the fungal keratitis, they diagnosed only clinical diagnosis in the 45% of the patient. This is so important to know that the diagnosis of the fungal keratitis, the clinical, is so difficult. In our hospital, only 20% of the patients that are arriving to the ER, they have the diagnosis of fungal keratitis. 80% of the patient doesn't have at all the diagnosis of fungal keratitis, and this is the reason that we have also poor outcomes. Yeah, and the other problem is the use of antimicrobials, that this is hampered the diagnosis and the recovery. And we know that the patient are using before, or was treated before for bacterial keratitis and was using corticosteroid, also the diagnosis is more difficult. This is the different spectrum. All of them have the same clinical feature, the feathery border. You can see in all of them, the borders are not clear. Some of them have satellite lesions and is elevating infiltration. You can see the spectrum in the corners is the more typical, but also in the center you can see some presentation that is not common, but also happen with hypopyon or without hypopyon. Hypopyon is not always present in the fungal keratitis. Regarding the microbiology, there are recognized more than 100 species of fungus. Mostly are septated filamentous, but also yeast. This is the most common in Saudi Arabia, the Aspergillus, and this is the presentation and the progression, of course. Look at the patient only in 10 days, look at the worsening of this case. In the same study that it was done in the hospital, in 124 patients and samples, most of them was Aspergillus following by Trichophyton. Trichophyton is not a common, really. It's only common in India and in Saudi Arabia, following by Candida, and after that was Fusarium and Alternaria. The patient with Aspergillus, This patient finished in therapeutic PKP in almost 90% of them, and finished in around 30% in enucleation. Really poor prognosis because we are diagnosing the Aspergillus really late. If the tissue feature, the prognosis is better, no enucleation, finish in therapeutic PKP more or less around 60% of them. Regarding the Candida, also the prognosis is better, even most of them finish in therapeutic PKP and some of them in enucleation. But I will highlight that almost 23% of the patients have a mixed infection, bacterial and fungal. But unfortunately, in the hospital, any of them was fungal and acanthamoeba at the same time. It was only fungal and bacterial. Regarding the diagnosis, it's important to do a good scrapping. Please don't use fluorescein. If you are using fluorescein, you are inactivating and the culture will become negative. You can use anesthesia. You can use an sterile Kimura spatula or needle or Excel, and you can use the different, and you can sit over the smear on glass. We're gonna do the potassium hydroxide is the higher positive predictive value. I will show later on, and we're gonna sit over the blood agar, chocolate agar, saburo agar, and also the broth. We have really high positivity around between 40 to 60% with a blood agar and chocolate agar, but you have to do also in this order. First, you have to see in the blood, continue with the chocolate, and finally the saburo. In our hospital, the gold standard is still the corneal biopsy. Most of the time we are doing the diagnosis with the corneal biopsy, or we have the diagnosis in the corneal bottom. And we are using it sometimes the confocal microscopy. In the confocal microscopy is important the branching. Look at the branching here. It had to be around 45 degrees. It's so important, but unfortunately we don't have a lot of positive results with confocal microscopy in our hospital. This is the sensitivity. The potassium hydroxide is the highest, 91%. Unfortunately, in the hospital, we are not doing potassium hydroxide. Confocal is reported in 96%, but definitely the PCR is becoming the gold standard in the following years. Why the molecular diagnosis? With the molecular diagnosis, it's a method that is more sensitive. We can use only a small sample size. In the case of the cornea, it's a small biopsy, but you need to include some tissue. We can also study the sequestration of microorganisms, for example, in the intraocular lens. It can be used in patients that was using antibiotics. There is no any problem. Also, you can identify fastidious bacteria or slow-growing bacteria. The gold standard of the molecular diagnosis is the sequencing. And all the publications that are recently done, all of them include the DNA sequencing. It's a fast technique. In only 6 hours, you can have the result that you have fungal or bacterial infection. It's an expensive gram. We can tell in gram, but it's a really fast technique, but at least you in 6 hours will know. And it's a quantitative technique. You can know how many the bacterial or viral load is more using in the viral infection disease than fungal and bacterial, but you can know the how many or how much viral particular loads you can count, and you can establish what is the severity of the disease. It's different when we are talking about the PCR in academic, in one university or in research, or in a laboratory that only their main is the diagnosis. There are several kits. Mostly for specific bacteria, tuberculosis, herpes simplex, but unfortunately for the bacterial kingdom and the fungal kingdom, there is no kits. But we are still doing the same procedure that always. PCR, and later on, when we identify this positive or negative for bacterial fungal infection, we are doing the sequencing. Regarding microbial keratitis, we can identify bacteria, fungal, specific Mycobacterium. This is really important after refractive surgery. Acanthamoeba is so useful, and viral infection. With molecular diagnosis with PCR, there are diagnoses a lot of new microorganisms we identify only with PCR. For example, this one in the cornea, Sarcospodium oculorum, or this other, Pyrinocheta keratinophila, that it was identified for the first time in the human being in the cornea. So this is also so the PCR is also important. It's an important tool because you can identify these new microorganisms. We also link some microorganisms to the disease. It's more specific for viral disease. It's not for fungal disease. Although there is one fungal disease that was related with a retinal disease, but this is not important. And also it's so important the genotyping. In the genotyping, it was used for the outbreaks, and also it was used looking at antifungal resistance. There are publishing articles more frequently about with the looking what is the specific resistance for some specific antifungal and related with the genes, and they are publishing in the last 5 years, and we will see more articles coming in the following years. In Barraquen-Barcelona, when I was working there, we run a study in 106 patients. In this patient, we tried to we did two diagnostic techniques. In some patients, we tried to confirm the initial diagnosis, the confirmation, we target the diagnosis, or in other patients, we use it as a screening. We request the PCR, but we didn't request a specific PCR. For example, we have an infection and we request PCR for bacteria, for fungal, for viral, for acanthamoeba, but it wasn't used as a method of screening. But in some patients, we targeted the diagnosis. So for example, this patient have acanthamoeba keratitis. We need the confirmation of the diagnosis, and we request it. So we divide this group in two different samples, in the one that was targeted or one screening, and we found that there was statistical significance. It is negative statistical significance when we are using this tool as a screening. But when we target, when we are looking the PCR for confirmation, also, when we have only the final result with PCR, was also statistical significant in comparison with when we have the final diagnosis with the culture or PCR plus culture or clinical, and in 4 cases it was unknown. But when the PCR was positive alone, in the patient with the targeted diagnosis, it was statistical significant. This is so important. Regarding keratitis, it was 49 patients. The PCR was positive in 71% of the acanthamoeba. In fungal, in this case, was only 22%. When the final diagnosis was done, even for PCR or culture, was not statistical significant, but when we are target the patient with fungal diagnosis, these 3 patients, we know that this is a fungal keratitis, and we try to the confirmation, effectively, in 100% of them, we confirm the disease. We confirm this is a fungal keratitis. And also it was important because we identified emerging pathogens. In the case of the fungal keratitis, we identify one postoperative, the Candida mesorugosa, and in 2 patients with Boston keratoprosthesis, one Candida parapsilosis and one Cryptococcus laurenti. It is so important because it's so difficult to identify these emerging pathogens. This PCR is so useful because in fungal keratitis, because the positive culture is only positive, the culture is only positive in around 50%. There is an excellent correlation with the PCR, when the PCR is positive and the culture is positive. And when we are doing the sequencing, it's stronger, the diagnosis. And it's frequent that we can use it in patients where they had negative culture or was treated previously. And it's also so important that there is not almost contamination. it could, you can identify some candidates, but it's more common when we are targeting bacterial keratitis, that is more common the contamination with the PCR, but not for fungal keratitis. This is an article that was published in 2008. This article, they run 195 samples, 87 was control, and they divide the group in between the culture positive or negative, and is what the bacterial or fungal etiology. In this article, it was so important that they established the diagnosis with negative culture, that was 52. In 46, they established the diagnosis with the PCR. So this is so useful technique. And you can see here that they had 96, the sample 96 were positive, but 52 of them were contaminated, 31 fungal and 21 bacterial. So this is so important to know that you can also have contamination with the PCR. There's the correlation between PCR positive and culture positive, what 94% in the fungal infection. Regarding sequenciation and culture positive, what in 89% is so high. And this result was also well correlated with this article published in 2010. This is a British military personnel that is deployed in Saudi Arabia and in Iraq, and there was a macular keratitis related with the contact lens. And in this article, they probably the correlation was 100% of them. This is the future, really, the PCR for the cornea. So this is more or less the review of the PCR. What happens when you have the staining positive, culture positive, PCR positive? This happens frequently, and you have the diagnosis. You have the staining positive, culture is positive, but the PCR is negative, is because you have polymerase inhibitors in wherever, in the gloves, in the Kimura spatula. It happens, this is sporadic, but in this case you have the diagnosis because your culture was positive. What happens, you have a staining positive, but the culture and the PCR negative, maybe dead microorganism, or again polymerase inhibitor. It could happen, never, we don't know, but you have to do a rescrape. With everything is negative, or the etiology is different, it's not infection etiology, or the sample was insufficient. It happens sometimes, but you don't have in this time diagnosis, you have to follow your patient. If the culture and PCR is positive, it's frequent, it's the same of the first situation. When you have a culture positive, but the PCR negative, staining positive, the staining is negative also, maybe you have contamination, also inhibitor again, you have to rescrape again. When you have a staining positive, PCR positive, happens sometimes, you have the diagnosis, maybe you have a low number of microorganisms, or slow growing microorganisms, or dead microorganisms. And finally, when you have only the PCR positive, maybe you have contamination, or you are establishing the diagnosis. This is so important to know about the PCR. Regarding the treatment, there are mainly three groups that are publishing the articles because they have the higher incidence in China, in India, and in the Basque compartment. And recently in Egypt, they are starting also to publish articles about the treatment and beautiful clinical trials. This is the group in India, in Arabic Hospital, Basque compartment, by Eduardo Alfonso, he is the chairman, and in Shandong in China by Dr. Li Xin. The polyins, we are treating the patient with polyins. They have really poor corneal penetration. Is only for a superficial infection, mainly natamycin. That natamycin is still the gold standard for the treatment of fungal keratitis. The concentration is 5%, mainly used for Fusarium and Aspergillus. Amphotericin B, they have a broad spectrum, but it's more specific for Candida. And the azole, we are using currently the voriconazole at 1%, that is UV-Fen, and also this is specific for Candida, Aspergillus, and Fusarium, but non-solari Fusarium. The first clinical trial that was published was the MOOD clinical trial, that is the mycotic ulcer treatment trial. They demonstrated the natamycin is superior to voriconazole for filamentous, regarding visual acuity, less perforation, or finally the penetrating keratoplasty. The natamycin also for better for fusarium when we are comparing the perforation in these cases, but there is no difference in non-fusarium between natamycin and voriconazole. This is what the first clinical trial published about the treatment that we have to follow this. We have to learn about these clinical trials. The other report about the same clinical trial, the mood, is that they reported decreasing the susceptibility to natamycin, and it was associated with the increase of the infiltrate of the scar size or the otose perforation, but it was not associated with the voriconazole. But when the susceptibility to natamycin is lower, we have more complication, but it's not related with the voriconazole. They describe also the resistance against the azoles, an increase of the resistance 2.4 more per year in the voriconazole. The voriconazole, they increased the resistance only in 1 year in 2010. The mix was 1.86 and increased to 3.79 in only 1 year. And this is related because they are using the voriconazole in the food industry. They are using massive in the food industry. We are increasing the resistance, and there is no association with the natamycin. So we have to take in consideration that the resistance against the voriconazole is increasing year after years. There is recently reported that in some countries the resistance is around between the 20 to 30%. So maybe in the following years also the resistance against voriconazole in the kingdom will be a big problem. What happens when we are using adjunctive oral voriconazole? This is the mood 2. This is some suggestion that the fusarium decrease the rate of perforation or the therapeutic keratoplasty, but they have more adverse events, around 50% of them. This is so important to know that, okay, maybe it's a mild decrease on the rate of perforation, but you have severe adverse effects, mainly hepatic disease. There is article also published by this group, the group of the was compartment, and they use also the PCR of the fusarium, and they demonstrate that the fusarium solani have the worst prognosis versus the fusarium non-solani, and also higher resistance against the voriconazole, and also demonstrate that natamycin have a good response against the fusarium solani, but not non-solarium. The same group, and also this group of China, they prove that the corticosteroid, they increase the risk of perforation and endophthalmitis. We have to take in consideration the nearby 50% of the patients are arriving to our ER. They are using corticosteroid when they are arriving to the ER. So this is one of the reasons why we have a really poor outcomes in the hospital. And we have to take in consideration that the use of topical corticosteroid after PKP reduce the inflammation and the immune reaction, but there is no increase in the rate of fungal recurrence. We have still in the discussion, and we have to start the corticosteroid 1 week or 2 weeks after the penetrating keratoplasty. The articles, it was published 2 weeks after, but right now we can start to use the corticosteroid 1 week after the surgery. This is other therapy, the intrastromal voriconazole or intrastromal amphotericin. It has to be used every 72 hours. You need to do several injections, not only 1, 4, or 5. Then these two articles are well described. The success is so high, but in this clinical trial, the name of this clinical trial is mycotic antimicrobial localized injection. In these clinical trials, in patients with moderate to severe filamentous fungal keratitis, mainly for Fusarium and Aspergillus, they demonstrate that the intrastromal injection in voriconazole increase the risk of perforation, and the month 3 have worse infiltration scar and worse visual acuity. This group, these people in India, they're right now in every country that you will attend, they always explain that please do not inject the patient, that this is becoming worse. But I will show later on that it's controversial. This treatment with chlorhexidine is an old treatment. This treatment started in 1997, 1998. There is always these two big clinical trials, and after that there is only a few reports. But in the Cochrane database, they review all the data, and they demonstrate that the chlorhexidine 0.2% is better at day 5 than natamycin at the half of the doses, and the day 21 is superior than the normal natamycin. The chlorhexidine is so cheap. And right now they are running a large clinical trials in Nepal. Unfortunately, it was stopped because of the COVID, but this clinical trial running by the Americans is because they are trying to launch in the game this chlorhexidine for these countries, developing countries, because it's excellent, better than the gold standard that is the natamycin, and it's so cheap. Regarding the corneal scraping, in the MUD study also, they demonstrate when you are doing in the protocol there, they are doing the scraping at day 0, day 3, and day 7. This is the protocol. And they demonstrate when you are doing the rescraping, you are increase the penetration of voriconazole, but you are affecting the visual acuity. When you are doing the rescraping on day 6, there are 30, even at day 6, even the treatment, 31% of the cultures are becoming positive. But this patient that even on the day 6, they are doing the rescraping and the culture is positive, finally they finish with the worst visual acuity, larger scar size, and most of them finish in perforation and therapeutic PKP. Mainly because if the patient is still positive at the day 6, is because they have a severe infection. The same study, they demonstrate that the risk of perforation when the culture is positive at the day 3 is 2 times, day 7 is 3.5 times, and when it's positive also at the day 7, have the worst visual acuity and larger scar at the month 3. So this is so important that we can rescrape this patient. But if the initial culture is positive and is also positive at day 3 or day 7, is meaning that we are treating a very difficult or very severe fungal keratitis, and the prognosis is worse. We can also treat the perforation or the epithelial defect with the isoacryl or the amniotic membrane or conjunctival flap. Is well described in the literature we are using, but there is no clinical trials. During no clinical trials, nobody has done a clinical trial about the glue of the amniotic membrane or conjunctival flaps, but we are using every day and it's so useful. There is some predictor about the therapeutic keratoplasty. In this study, in the MUD2, they demonstrated the patient with hypopion, when they are compromised the posterior 1/3 of the stroma, there is a for each millimeter of increase of the size of the infiltrate, there is 1.37 increase the risk of perforation, or the patient will finish in therapeutic keratoplasty. The progression and endophthalmitis worldwide is only, there are described only 0.5% of the culture-proven endophthalmitis progress to the keratitis progress to endophthalmitis, but most of them are fungal keratitis, not bacterial, fungal. The risk factors are the steroid use, previous suturing, previous surgery, large corneal ulcer, larger than 10 millimeters, hypopion, aphakia, but in the kingdom, the risk of progression is higher. In fungal keratitis is 18.5%, mainly after extracapsular cataract surgery. That is compromised, more or less, is 65% of the patients. Also, in the kingdom, finally, 54% of the patients finish in penetrating keratoplasty, and there is, in this patient that finish in penetrating keratoplasty, around the 14% of them finish in endophthalmitis and finally in evisceration. They recommended that the penetrating keratoplasty had to be done 2 and 4 weeks after we start the medical treatment with impregnation of the cornea with the systemic and topical treatment. And also it will describe the early therapeutic penetrating keratoplasty had better outcomes, but the failure of the penetrating keratoplasty is so high. This is the 48% at GR1, but it increased nearby to 90% at the GR5. The prognosis is really, really bad. Regarding the fusarium, is also doing the study by PCR that demonstrate that the therapeutic penetrating keratoplasty is the patient with fusarium surrounding, many of them will finish in penetrating keratoplasty and is related with the resistance against the natamycin. Also, they study that the patient when they have this mycotoxin, FUN1, they have finally worse visual acuity and most of them finish in therapeutic keratoplasty. This is also studies done in Bascom Palmer. Regarding laminar keratoplasty, the group that they have more experience is in China. This, they recommend that the patient have started treatment for at least 2 weeks. After that, they're gonna do the penetrating keratoplasty, but the descending membrane had to be intact. There is no compromise at all with the descending membrane. Even you are doing, they're recommending to do a manual technique, no big bubble. But they have worse outcome in aspergillus, and you're related with the use of steroid or cyclosporine, ipopion of endothelial plaque before laminar keratoplasty. When we are comparing in this study, it's a comparative study, there is no difference between the laminar keratoplasty, penetrating keratoplasty, but most of the patients with penetrating keratoplasty, maybe it's more advanced disease, compromised the membranes, they progress to endophthalmitis in half of them, and of course, the survival of the adult is better and have also better visual acuity. This study is so important. The study is TST protocol, topical, systemic, and targeted therapy. The success rate of this study is around 80%, and they have only perforation in 7% of the cases, and the keratoplasty was only done in 20% of them. Right now, this protocol is becoming the gold standard. It was published by Dr. Agarwal in China, in India, excuse me. This protocol, all the patients start with the natamycin. If the patient that the pen, if the ulcer is high, is larger than 5 millimeters, or the depth of the ulcer is deeper than 50%, they start the systemic voriconazole. If there is a good response, they continue with the natamycin. There is poor response, they add the topical voriconazole. If there is a good response, they continue with the same treatment. There is a poor response, they start with the stromal intracameral injection. And this is still a poor response. Finally, they're gonna go for therapeutic keratoplasty. If the intrastomal fail, also they're gonna go for the therapeutic keratoplasty, and they are continue the same treatment and injections. Finally, when the injection work, they continue with the treatment, natamycin plus voriconazole, and this is the outcome, excellent outcomes. Right now, update and controversial is about the photoactivated chromophore for infection keratitis, PAC, el PAC cross-linking, but there is more PACs. The cross-linking is not the only one. But in the clinical trials, it was demonstrated that the cross-linking group for fungal keratitis, they have more perforation than the non-cross-linking group, and it's not recommended at all. And the same result was in this other clinical trial published recently, that the group with filamentous fungal keratitis have worse visual acuity, and there is no difference between the infiltrates or scarcase or epithelialization or adverse effects. Right now, it's not recommended because even there is a lot of case report that this is a good, with excellent outcomes, the clinical trial demonstrate that the cross-linking for fungal keratitis is not working. There is also PAC with rose bengal antimicrobial therapy. This is in the Bascom Palmer. This is the first case report in 2017 in a patient with one fusarium. They use the rose bengal at 0.1% or 0.2%. They are doing one drop every 2 minutes for 30 minutes. And after that, with a custom-made green LED light for 15 minutes, they are doing some light of cross-linking. This is the patient that they report first. This is the day 1 of the patient arrived to the hospital. At day 44, there was progression. They did that this day. You can see still there some staining to the rose bengal. And the patient finally were improved slowly, but the patient finally they controlled the infection. After that, they start a real research project, and they demonstrate that it's safe for the endothelium, is safe for the iris, about the penetration, about the keratinocytes, about the limbal stem cell. There are different articles. And in December 2019, they published this case series in ET patient, and they're comparing the successful rose bengal therapy based on failed. Failed, they consider failed when they have perforation. In this case, it was 5 patients. They include patients with acanthamoeba keratitis, fusarium, and curvalaria pseudomonas. And in fusarium, it was not good as expected, and it was published before, but there are still studying about this PAC rose bengal antimacular therapy. Maybe in the future it will be another tool. Also, there is well described the PAC with argon laser. It was described in 2013 by one ophthalmologist in Argentina, and later on it using in the United States, and also using in India. With the normal argon green laser, the patient was the chromophore was the fluorescent at 0.25% of the riboflavin. They are try to do a burn over the surface of the cornea. They try to do a blanching of the corneal stroma, and also they have to they describe. I didn't include the photography, but there is a small bubble cavitation into the stroma. They are creating a burn. There is some article published about these people in India, and they also they recommend to do this therapy with argon laser, because the argon laser is cheaper, and the patient have a faster healing and recovery, only 2 to 4 weeks in comparison with the normal medical treatment that this takes between 8 to 12 weeks. They have the patient also faster epithelialization. 90% of them have epithelialization after between the week 4 to 6. But unfortunately, because there is a burn in the surface and in the stroma, there is no improvement of the visual acuity, but you can control the disease. Finally, there is some special consideration. One is Boston keratoplasticus. It's well known that infection with Boston keratoplasticus is not related with fusarium, is not related with the aspergillus, is related with candida. And this is the reason why we are using prophylactic amphotericin for 2 weeks every 3 months. This is one of my cases. You can see here, finally the patient was successfully treated, but this is the typical clinical presentation. The other, this was the thesis of Dr. Rawan that he showed it was related with her thesis that he presented 1 month ago. Is about the ring contamination by candida, mainly in this sick patient. You can see this is a patient of the hospital, and in this area, in the superior area, you can see the whitish infiltrate. Unfortunately, we know that we have poor penetration of topical treatment, and this patient finishes again in regrafting, and the prognosis is really poor. And recently, Dr. Selma is running right now a retrospective study about the infectious keratitis in patients with the congenital glaucoma. This is one example of one patient in the hospital. That this is the patient when he arrived here when he has only 2 months old, and finally the patient finished when he has 5 years old with bilateral keratitis and endophthalmitis and bilateral blindness. It happened in the hospital. We're going to see what happened with this retrospective study, but we have to take consideration in this specific population. The take-home message. First, it's important to do an early diagnosis, the fungal keratitis. We need to start to work with the PCR. It's difficult because there is not a specific test for fungal infection. Okay, there's need experience of the technician. It's difficult, but we have to implement in the hospital. The medical therapy, the gold standard is still the natamycin, mainly for Fusarium and Aspergillus. The voriconazole oral and intrasomal injection is when they have progression of patients with severe keratitis and was described also in the clinical trials. Surgical therapy, early surgery is better than late surgery before the hypopyon or before the decimal compromise. We know that worldwide 70% of the patients finish finally in surgery. But we know that the fungal keratitis is a disease that finally need a surgical treatment. We have to do the surgery early. LKP, PKP, this depends on the posterior stromal infiltration, it depends on the skill of the surgeon. We have to avoid the steroid the first week after the surgery, and we have to replace with cyclosporin. And the future is the PCR clearly. We have to study this fungal keratitis with PCR and the PAC, the phototherapy with the PAC. Cheaper, faster, and we are diagnosing the patient fast, early with the PCR, and we are treating also early, we want to improve the outcomes. Thank you very much for your time. If they have any question, I open to attend the questions.
Thanks a lot, Hernan, for an excellent talk, as always. A lot of information and knowledge about all these things. I think I totally agree that most of our current knowledge about fungal keratitis is owed to the group in Irvine, basically. All these MUT group. I mean, they have done excellent studies and they have showed that cross-linking has no role, intrastromal, yeah, suspicious, oral voriconazole, maybe no role. But again, I think we have to take them as a pinch of salt because they're based on observations. These are not scientific studies, these are observation studies. So, as you said, the TST protocol from Northern India may be better one, but again, that was a single arm study, so it's difficult to say. But I think I totally agree. PCR is the future. The problem is we don't have any commercial kit for fungal PCR.
Yes, there is no kit, unfortunately.
I mean, the companies that do it for the research purposes, like Thermo Fisher, they make it, but that's just for the research purpose. There is no commercial lab, there is no commercial kit. So unless we develop our own lab for this, or use a reference lab, I think the closest one would be in Spain. I don't think so. There is anyone closer anywhere. But interesting, yeah. Any questions from the audience for Dr. Osorio?
Good evening, good afternoon.
Hi, Ziad.
Thank you very much for this talk, Dr. Hernan. You talked a lot about therapeutic keratoplasty being probably the endpoint for a lot of cases. Can you elaborate more on what happens after that? A recurrence or management in regards to decreasing the rate of recurrence, pre-op and post-op medications or interventions that are needed?
The recommendation of the clinical trials is you have to treat the patient or you have to do an impregnation with topical and systemic treatment at least 2 weeks before. If you are doing the impregnation and the treatment 2 weeks before, the prognosis improves. This is the first recommendation. Regarding the treatment after, don't start the corticosteroid the first week. You can start the corticosteroid topical corticosteroid after the first week. The first week you have to use only cyclosporin. You have to continue the treatment with natamycin mainly. Unfortunately, the natamycin is expensive. The natamycin is becoming in only 5mm bottle. So you have to use the natamycin Q4 hour, Q6 hour, not Q1 hour. You're using the natamycin Q1 hour. In only 48 hours, you don't have enough. You're finishing the bottle. This is so important to take in consideration. This is recommended also. There is one study that you can continue the injection, the intrasomal injection after the penetrating keratoplasty. Regarding the surgery, LKP or PKP, it depends on the depth of the infiltration. If reaching the decimal, you have to do PKP, or you have a inflammatory endothelial plaque, you have to do PKP because the prognosis is poor for the LKP. After the treatment, how many weeks or months you have to continue the topical treatment? Maybe you have to continue the topical treatment for at least 1 more month and taper later on the topical antifungal for another more month. Sometimes when you have recurrence, you have to continue the treatment for 3 to 6 months prophylactic. You can use voriconazole 3 times a day or natamycin 3 times a day easily, or amphotericin 3 times a day for 3 months, 6 months. I treat some patients with 6 months, 3 times a day, and finally I control the infection. Regarding the systemic treatment, it's controversial. It's controversial. You can start the voriconazole, but as I was explaining, I showed in one clinical trial, they are becoming more resistant against voriconazole because it's used in the food industry, massive use in food industry. That maybe in the future we have to start to use again other kind of azoles. More or less, this is the review of the clinical trials. And regarding the outcomes, at the first years, only 30% of them are clear. 70 fail, and at year 5, the failure is around 90%. The prognosis is really, really poor. It's really poor even in Europe, even in Netherlands, that it was poor recently, or in Australia it was poor also the last year. It have the same outcomes. The outcome that we have here in the hospital, every day we are seeing this patient we are doing the therapeutic PKP for fungal keratitis, and after only 1 year or 2 years, all of them fail. Is normal. It's normal. The only way to improve is with following the result of this clinical trial, following this observation that this group that really are studied fungal keratitis, and maybe we're going to improve. And the other is the TST. The TST, this is the article, and this is a clinical trial that they describe the better protocol. And we start to follow this protocol in the hospital more or less 6 months ago. The patient, we want to start with the topical treatment, and after that we're going to move for systemic treatment when they have a severe keratitis. We're going to start also the injections, but we have to increase the injection more frequently. Sometimes I am doing 1 injection, and maybe the next injection will be in 2 weeks. No, we have to do the injection every 3 days, and maybe we want to increase the prognosis and the outcome of this patient. And the other thing, we have to do early surgeries. We know that 70-80% of them finally finish in surgery. You have to do the surgery early.
Hello.
Hi, Omar.
Hi, how are you? Thank you, Dr. Osorio, for this excellent lecture. You know, fungal keratitis is really like a nightmare. And first thing is, usually, nearly most of the time, we get the worst cases with advanced keratitis. Most of the time, they are either reaching the limbus or about to reach the limbus. And there is a big difference between fungal keratitis and bacterial keratitis in terms of reaching the limbus. If it tends to reach the limbus in bacterial keratitis, then the body will take care of it. In fungal keratitis, absolutely the opposite. So if the fungi get access to the sclera, then it is a nightmare. This is one thing. The other thing, we prescribe medications, but are we sure that the medications are applied properly? This is a big question. For example, it is a big concern really. If you write, for example, 3 or 5 medications for a patient, for example, dilating drop cyclopedia to prevent the synechia, if you give fortified, for example, and antifungal, then I think we all should know that all these medications will be applied on the eye within maybe 1 or 2 minutes. Which one works? Probably none of them. So the other thing, some of the antifungal medications get affected by light, and whether they are really kept in containers that prevent light damage to the antifungal medications or not, this is a big question. Sometimes we wonder why our amphotericin doesn't work like their amphotericin. Maybe our amphotericin did not reach the cornea actually to start with. This is one important aspect. True, in fungal keratitis, one has to have a low threshold for surgery. But I wonder regarding this Indian protocol: observe, start 1 medication, observe, and start 1 medication, and observe maybe 5 or 6 stages. I wonder how they observe the improvement or the worsening. That's really I cannot imagine myself doing this. It's very difficult actually to judge the progression in fungi. Usually, most of the time, it's very slow. And but what I usually do in treating fungal keratitis is treat as in TB. Actually, I treat with all the possible medications available. Even sometimes I add povidone once daily to the patient, once or twice. Regarding the ECC and the higher fungal keratitis at that era, at that time, most of the eye banks did not include chlorhexidine in the storage media. Besides those who undergo ECC, who underwent ECC at an earlier age at Kekish, were very old with trachomatous scarring, dry eye, bad ocular surface, and even the selection at that time, I think it was not as careful as it is today. Today, we tend to avoid keratoplasty in the old, and we try to do cataract surgery in the way of, for example, phaco, even with through a difficult view, and to avoid keratoplasty. Most of the time, when Kekish started, it was started by Western staff. Corneal scar treatment is keratoplasty. And so many cases ended with trouble. Now I think the approach is more careful, and besides the hygiene and the presentation of the disease is different. Most of the trachomatous scars were operated upon earlier, I think, at the time of Kekish. Nowadays, you hardly find a case of very dense trachomatous corneal scarring. So I think these are my comment, and thank you very much.
I have a question, Dr. Hernan, if you allow me.
Yes, of course.
As you know, we are in the emergency room. We are the first line with the residents there to take care of these cases. But now the the classical teaching is to start to do scraping and then start the patient empirically on antibacterial. Usually will not, I'm seeing some of the colleagues that not starting the antifungal till proven, culture proven. Is there any way to, from the beginning, to change our classical teaching to the residents that this is most likely a fungal and you have to start antifungal from the beginning? Does it going to change the final prognosis in such cases and delay the need for BKB or any other further, worsening of the condition?
In the study published by Dr. Zavallas tenía, only 20% of the patients have the initial diagnosis was the fungal keratitis. 80% of them didn't have the diagnosis in the ER. I always say our protocol is we are taking the initial culture. We are not stopping the medication, the previous medication. We are taking immediately the patient is arriving to the ER, the culture, the samples. My recommendation is please avoid the fluorescein. Most of the residents, the first thing that they're doing is put one drop of fluorescein because they want to know what is the size of the epithelial defect. This is not important. We are treating an infection. We are not treating the epithelial defect. We try to we try to establish the diagnosis and we try to try the proper treatment. If you are the first thing that you are thinking is to put one drop of fluorescein, our culture will become negative in 100% of the cases. This is the most important thing. Please don't put one drop of fluorescein. Take the samples. You will take the samples, do the proper seed in the culture plates, and 40 hours later, we wanna decide if the culture is becoming positive or not. It's bacteria or it's fungal, but if the suspicion is high suspicion about the fungal keratitis, we are doing biopsies. And with the Dr. Asa Maktevi, she really helped us in a lot of patients when we are studying the diagnosis by biopsy. The biopsy is still the gold standard in our hospital. In the article published by Dr. Zavallas tenía 100% of them. This is what the gold standard, what the inclusion criteria. And in our practice in the hospital, I have also the same feeling that I am doing the diagnosis of this patient, also the Cantamoeba with biopsy. And regarding to start the treatment early, sometimes we are continuing the treatment and the patient starting elsewhere for when the suspicion is high. But as Dr. Kirate explained us, most of the patients are coming to the ER with the infiltrate limbal to limbal area. This is a really advanced severe disease with sclera compromises, perforated. The prognosis is really poor. For me, it's more important the diagnosis. Don't put fluorescein, take the samples, good samples, and after that we will try to follow the best protocol, or we have to establish the better treatment for the patient. I don't know the opinion of Dr. Ahad, Dr. Kirat.
No, I think I totally agree. I mean, I think the only thing is if there is a very clear history of vegetative trauma, I think empirically you can start on natamycin or voriconazole. Otherwise, I think we have to wait. The most important thing is the diagnosis and the proper management by the anterior segment team. I think that's more important. I think for the sake of the time, we have to conclude here. It was an excellent talk by Dr. Osorio. And if there are any questions, I think we can ask him later on in personal or by messaging him. Thanks a lot.
Thank you very much. We have to see about the argon laser. It's cheap and it's worked really well. Thank you, everybody. Goodbye.
Thanks a lot. Thank you.